Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, students. Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. My name is Crisel Merducanes, nurse educator, teaching medical and surgical nursing. As continuation to our topic on the management of patients with chest and lower respiratory tract disorders, we have pleural conditions. These are disorders that involve the membranes covering the lungs or the visceral pleura and the surface of the chest, the parietal pleura, or disorders affecting the pleural space. This includes PLEURISY, pleural effusion, and EMPYEMA. Now let's discuss about PLEURISY. It is also known as pleuritis. It refers to inflammation of both layers of the pleurae, the parietal and visceral. For the clinical manifestations, we have pleuritic pain. The key characteristic of pleuritic pain is its relationship to the respiratory movement. Taking a deep breath, coughing, or sneezing worsens the pain. Pleuritic pain is limited in distribution rather than diffuse. It usually occurs only on one side. The pain may become minimal or absent when the breath is held. It may be localized or radiate to the shoulder or abdomen. Later, a pleural fluid develops and the pain decreases. Now let's proceed to the assessment and diagnostic findings. In the early period when little fluid has accumulated, a pleural friction rub can be heard with a stethoscope, only to disappear later as more fluid accumulates and separates the inflamed pleural spaces or surfaces. Diagnostic tests may include chest X-rays, sputum analysis, thoracentesis to obtain a specimen of pleural fluid for examination, and less commonly, a pleural biopsy. For the medical management, the goal is to discover the underlying condition causing the pleurisy and to relieve pain. So we have to monitor for signs and symptoms. We have to administer analgesics for pain, topical application of heat or cold, and non-steroidal anti-inflammatory drugs administration or NSAIDs. Now let's proceed to the nursing management. We have to enhance comfort by way of turning our patients frequently onto the affected side to splint the chest wall and reduce the stretching of the pleurae. The nurse also educates the patient to use the hands or a pillow to splint the rib cage while coughing. Now let's proceed to pleural effusion. A collection of fluid in the pleural space is rarely a primary disease process. It is usually secondary to other diseases. Bronchogenic carcinoma, it is the most common malignancy associated with a pleural effusion. For the clinical manifestations, it is caused by underlying diseases. The severity of symptoms is determined by the size of the effusion, the speed of its formation, and the underlying lung disease. For large pleural effusion, it causes dyspnea. For small to moderate pleural effusion, this causes minimal or no dyspnea at all. For the assessment and diagnostic findings, for the physical examination, we would note decreased or absent breath sounds, decreased fremitus, a dull flat sound on percussion, respiratory distress, and tracheal deviation. We also perform chest x-ray. Also chest CT scan, thoracentesis as well, and bacterial culture. For the medical management, the treatment goals here is to discover the underlying cause of the pleural effusion, to relieve discomfort, dyspnea, and respiratory compromise. We also perform thoracentesis. It is performed to remove fluid to obtain a specimen for analysis and to relieve dyspnea and respiratory compromise. It may be performed under ultrasound guidance. Depending on the size of the pleural effusion, the patient may be treated by removing the fluid during the thoracentesis procedure or by inserting a chest tube connected to a water-sealed drainage system or suction to evacuate the pleural space and re-expand the lungs. We also have a procedure called chemical pleuridesis. It may be performed to obliterate the pleural space and prevent the reaccumulation of fluid. A chemically irritating agent, such as talc or another chemical irritant, is instilled or aerosolized into the pleural space. With the chest tube approach, after the agent is instilled, the chest tube is clamped for 60 to 90 minutes, and the patient is assisted to assume various positions to promote uniform distribution of the agent and to maximize its contact with the pleural surfaces. The tube is unclamped as prescribed, and chest drainage may be continued several days longer to prevent reaccumulation of fluid and to promote the formation of adhesions between the visceral and parietal pleurae. Now let's proceed to the nursing management. We have to support the medical regimen, and we also have to prepare and position the patient for thoracentesis and offer support throughout the procedure. Also, we have to monitor the chest tube system. Patient and family education about the management is very important. Now let's discuss about EMPYEMA. It is an accumulation of thick, purulent fluid within the pleural space, often with fibrin development, and a loculated, walled-off area where infection is located. For the clinical manifestation, we have it is similar to acute respiratory infection or pneumonia. For immunocompromised patients, symptoms may be vague. For the assessment and diagnostic procedures, we have chest auscultation. This reveals findings such as decreased or absent breath sound over the affected area, dullness on chest, decreased fremitus. We also have a diagnosis. The diagnosis, is established by chest CT scan. And diagnostic thoracentesis under ultrasound guidance may be performed. Now let's discuss the medical management. So the goal here is to drain the pleural cavity and to achieve complete expansion of the lung. So we administer antibiotics to our patient for bacterial infection. We also have to insert chest tubes to drain the pleural cavity. Now let's proceed to the nursing management. So we have to help our patients cope with the condition. Also, we have to instruct lung expanding breathing exercises. Care specific to the method of drainage of the pleural fluid. Patient and family education on the care of drainage system is very important. Now let's discuss about pulmonary edema. It is defined as abnormal accumulation of fluid in the lung tissue, the alveolar space, or both. It is a severe, life-threatening condition. And it is classified as two cardiogenic and non-cardiogenic pulmonary edema. For this lesson, we will discuss the non-cardiogenic pulmonary edema. For the non-cardiogenic pulmonary edema, it occurs due to damage of the pulmonary capillary lining, and it may be due to direct injury to the lungs. Now let's discuss about acute respiratory failure. For now, we will discuss the respiratory failure itself. It is a sudden and life-threatening deterioration of the gas exchange function of the lungs and indicates failure of the lungs to provide adequate oxygen or ventilation for the blood. For the acute respiratory failure, it is defined as a decrease in arterial oxygen tension to less than 50 millimeters of mercury. This would indicate hypoxemia and an increase in arterial carbon dioxide tension to greater than 50 millimeters of mercury. That condition is called hypercapnia, with an arterial pH level of less than 7.35. For chronic respiratory failure, it is defined as deterioration in the gas exchange function of the lung that has developed insidiously or has persisted for a long period after an episode of acute respiratory failure. Now let's have the clinical manifestations specific for acute respiratory failure. For the early signs, we have restlessness, fatigue, headache, dyspnea, air hunger, tachycardia, and increased blood pressure. For the medical management of acute respiratory failure, we have here goal. First is to correct the underlying cause and to restore adequate gas exchange in the lung. And this is made possible by endotracheal intubation and mechanical ventilation. The purpose of this is to maintain adequate ventilation and oxygenation while the underlying cause is corrected. For the nursing management, we have to assist the doctor in the intubation procedure and maintain mechanical ventilator or ventilation. We also have to assess respiratory status. This includes assessing the level of consciousness, arterial blood gases analysis, and oximetry, as well as the vital signs monitoring. We also have to maintain the skin integrity and perform hygiene measures by providing a turning schedule. We have to perform mouth and skin care, range of motion exercises as well. Now let's proceed to acute respiratory distress syndrome or ARDS. It can be thought of as a spectrum of disease from its milder form, acute lung injury, to its most severe form of fulminate, life-threatening ARDS. The clinical syndrome characterized by a severe inflammatory process causing diffuse alveolar damage that results in, first, sudden and progressive pulmonary edema, second, increasing bilateral infiltrates on chest X-ray, third, hypoxemia unresponsive to oxygen, and lastly, and the fourth, is absence of an elevated left arterial pressure. For the clinical manifestations, we have it closely resembles severe pulmonary edema signs and symptoms. For acute phase, marked by rapid onset of severe dyspnea less than 72 hours after the precipitating event. For the assessment and diagnostic findings, first, we have to perform physical examination. You will note an intercostal retraction and crackles. For the diagnostics, we perform plasma brain natriuretic peptide BNP levels laboratory. Okay? This is helpful in distinguishing ARDS from cardiogenic pulmonary edema. We also perform transthoracic echocardiography. It is used if the BNP is not conclusive. And also we have a procedure called pulmonary artery catheterization. So these are the possible diagnostic and laboratory tests that we should perform in order to diagnose our patients with acute respiratory distress syndrome. Now let's proceed to the medical management. The primary focus of our management is the identification and treatment of the underlying condition. Aggressive, supportive care must be provided to compensate for the severe respiratory dysfunction. We also have to provide circulatory support by way of oxygen supplementation. Also, we have to provide adequate fluid volume and nutritional support. We also have the pharmacologic therapy by way of administering drugs such as neuromuscular blocking agents, sedatives, and analgesics. For the nursing management, we have the general measures. A patient with ARDS is critically ill and requires close monitoring in an intensive care unit. Most of the respiratory modalities that we have discussed are used in this situation. Oxygen administration, nebulizer therapy, chest physiotherapy, endotracheal intubation or tracheostomy, mechanical ventilation, suctioning, and bronchoscopy. Frequent assessment of the patient's status is necessary to evaluate the effectiveness of the treatment. We also have the ventilator considerations. If the patient is intubated and receiving mechanical ventilator with PEEP, several considerations must be addressed. PEEP, which causes increased end expiratory pressure, is an unnatural pattern of breathing and feels strange to the patient. The patient may be anxious and fight the ventilator. Nursing assessment is important to identify problems with ventilation that may be causing the anxiety reaction. Tube blockage by kinking or retained secretions, other acute respiratory problems such as pain and pneumothorax, a sudden decrease in the oxygen level, the level of dyspnea, or ventilation malfunction. In some cases, sedation may be required to decrease the patient's oxygen consumption, allow ventilation to provide full support of ventilation, and decrease the patient's anxiety. So these are the ventilator considerations that nurses should look into. Now let's proceed to pulmonary hypertension. It is characterized by elevated pulmonary arterial pressure and secondary right heart ventricular failure. Suspected in a patient with dyspnea, with exertion without other clinical manifestation. We have here clinical classifications of pulmonary hypertension. First, we have the group 1, the pulmonary arterial hypertension. We also have group 2, pulmonary hypertension due to left heart disease. Group 3, we have your pulmonary hypertension due to lung diseases or hypoxemia. Group 4, we have chronic thromboembolic pulmonary hypertension. And lastly, Group 5, pulmonary hypertension with unclear multifactorial mechanisms. For Group 1, which is the pulmonary arterial hypertension, we have sporadic idiopathic pulmonary artery hypertension, heritable idiopathic pulmonary arterial hypertension, drug and toxin-induced pulmonary arterial hypertension, and pulmonary arterial hypertension due to diseases such as connective tissues disorders, HIV infection, portal hypertension, and congenital heart disease. Okay? So these are the conditions under your Group 1 pulmonary arterial hypertension. Now let's proceed to Group 2 pulmonary hypertension due to left heart failure. So we have your systolic dysfunction, diastolic dysfunction, and valvular dysfunctions. Okay? So these are the dysfunctions or alterations under your pulmonary hypertension due to left heart disease. Now let's have the Group 3 pulmonary hypertension due to lung diseases or hypoxemia. We have your chronic obstructive pulmonary disease, interstitial lung disease, mixed restrictive and obstructive lung disease, sleep disordered breathing. For Group 4, we have the chronic thromboembolic pulmonary hypertension. This is due to thromboembolic occlusion of the proximal or distal pulmonary vasculature. For Group 5, we have your pulmonary hypertension with unclear multifactorial mechanisms. We have disorders like hematologic disorders, systemic disorders. Examples is your sarcoidosis. We also have your metabolic disorders. So these are the disorders under your Group 5. Now let's proceed to the clinical manifestations of your pulmonary hypertension. First, we have your dyspnea, which is considered as the main symptom. Substernal chest pain. Patient may experience weakness, fatigue, syncope, occasional hemoptysis, signs of right-sided heart failure, anorexia, abdominal pain in the right upper quadrant. For the assessment and diagnostic findings, first we have to obtain complete history and physical examination. Also, we perform chest X-ray, pulmonary function test or studies. We also perform your ECG and echocardiogram. For the medical management, the goal here is to manage the underlying condition related to pulmonary hypertension if the cause is unknown. So we administer diuretics. Also, we give oxygen supplementation, anticoagulants administration, digoxin, exercise training. So these are the possible medical management under your pulmonary hypertension. Now let's proceed to your pharmacologic therapy. So we administer calcium channel blockers, prostanoids. Your prostanoids mimic the effect of the prostaglandin, prostacyclin. Prostacyclin relaxes vascular smooth muscle by stimulating the production of cyclic 3,5-adenosine monophosphate or your AMP and inhibits the growth of smooth muscle cells. We also have your endothelin antagonists. Also, we have your phosphodiesterase 5 inhibitors. Now let's proceed to the surgical management. We have your lung transplantation. It remains an option for a select group of patients with pulmonary hypertension who are refractory to medical therapy. bilateral lung or heart-lung transplantation is the procedure of choice. We also have your arterial septostomy. It may be considered for selected patients with severe disease. This procedure results in shunting of blood from the right side of the heart to the left, decreasing the strain on the right side of the heart and maintaining left ventricular output. So these are the two possible surgical management under your pulmonary hypertension. Now let's proceed to the nursing management. So our goal here is to identify patients at high risk of pulmonary hypertension. So we need to watch out for possible signs and symptoms, administer oxygen appropriately, patient and family education of home oxygen therapy, education about the treatment and regimen, education about the treatment regimen, care of the emotional and psychological aspects of our patient. Formal and informal support groups for patients and families are extremely valuable.